Hi, everybody. I'm Bill Wilmer. I'm a nephrologist in the area. I am with a group called Kidney Specialists Incorporated. Many of you may know who we are. And I'm also on the board of directors and the medical advisory board for the National Kidney Foundation of Ohio, in particular Central Ohio. And some of these slides that I'm going to present to you are actually NKF slides that we developed to give this similar talk to other groups. This is a topic that's going to keep you very busy. Hopefully you're not going to go to sleep with it, but I'm going to jam a lot of information in about 55, 60 minutes, so I apologize early. We could do an entire symposium on this topic, but I asked to be part of this symposium because introducing to you all the concept of chronic kidney disease workup and management, and in particular emphasizing, and this is going to be a little bit of a shock, emphasizing the need for primary care providers to do a lot of the legwork and a lot of the management of patients with CKD. That's something that's a little bit novel, and it's something very important to us as the nephrologists who will be receiving, hopefully, some of your referrals for more advanced chronic kidney disease. So I want to take a little bit of the mystery out of CKD, and I want to give you a little bit of education about this as well. Our goals are exactly that, to teach you how to evaluate chronic kidney disease patients, not only to evaluate them, but also to treat them. And I know that many of you in the audience are primary care providers. Many of you are not. Maybe you're working with specialists, cardiologists, endocrinologists, et cetera. Chronic kidney disease is so out there. You're gonna hopefully get something from this talk because you're gonna have patients with CKD every day of your working career. Now, as I said, there's a lot to this talk. Copies of these slides will be given to you, so you can scribble and you can add to the side. I'm also going to give you a handout that has some case scenarios. Don't read them now, but they're going to be available to illustrate some of the points that I want to make. And then towards the end of this talk, we're going to talk about therapeutic strategies. And the new kid on the block, as you know, are the SGLT2 inhibitors, your Farxiga, your Invokana, your Jardiance. And it's a really interesting group of medications. And from the nephrologist point of view, I think it's important you all know how they work. But instead of going through slides on how they work, I've spared you that point, and I've got a couple slides made up in a little handout explaining how that type of medication works, and you can look through that as well. How it prevents cardiac disease, heart failure, promotes weight loss, and helps kidney disease. Many years ago, when my partners and I were in residency, we really didn't have the CKD staging criteria. The CKD staging criteria has evolved over the last couple decades, in part because we realized patients were experiencing elevated creatinine, representing lower kidney function, and there was not a kind of firm guideline for all the other physicians, primary care providers in particular, for saying who needs to see a specialist and what do we need to do to control blood pressures and other risk factors. The main reason this was developed was to try to prevent our patients from getting to that final stage of needing dialysis. And much of this was not only to help prevent morbidity and mortality and the cost to families of having a family member on dialysis, but also due to the financial costs. Right now, there's about 750,000 people in this country on dialysis. That's from the U.S. Renal Data Service. They're always 2 or 3 years late in their report. Staggeringly, $80,000 a year, all costs, medications, nursing, doctors, $80,000 a year to take care of a dialysis patient. Medicare and commercial insurance together. It's so expensive that in the 70s, even a young person could apply for Medicare to get dialysis services. It was so expensive that it was actually President Johnson who slid dialysis care under the Medicare umbrella. Right now, 1% of all Medicare patients have dialysis needs, ESRD, but it consumes 7% of the Medicare budget. Wow, 7%. It almost exceeds the entire National Institute of Health research budget. Transplantation's the answer, but we have 100,000 people on the list at any given time, 21,000 transplants a year. Lots of people die waiting for a kidney. So that's what we're trying to prevent by early staging of chronic kidney disease. The National Kidney Foundation in the United States, they have sister agencies in other countries, but the United States NKF initiated a program called Kidney Disease Improving Global Outcomes, KDIGO. And you're going to hear me talk about KDIGO quite a bit in this talk because they're really good at developing algorithms and guidelines. They're universally accepted all across the world. And they were actually the entity that said what's called chronic kidney disease, stage 3, when your filtering rate's less than 60% and it's been stable for 3 months, or if a patient has proteinuria. By the way, that stable for 3 months is really important. Somebody's in the hospital and their GFR goes from 70 to 20 for a couple of days. It doesn't mean they have CKD. It has to be stable for 3 months. But the problem is, like lots of entities in medicine, KDIGO I call the best kept secret. Many of you have never heard about it. We haven't been able to market outside the nephrology community. KDIGO has spotlighted on the CKD management crisis. Here's the crisis. There's over 20 million adults with chronic kidney disease. There's 10,000 nephrologists and including nephrology advanced practitioners. There's more work than we can ever handle. And so there is a suggestion, a request, an ask that PCPs are expected to screen and manage early stages of chronic kidney disease, particularly if you have no proteinuria or minimal proteinuria and other risk factors. Now, you'll see throughout this talk a star, a little red star. I'm going to put red stars on the topics that I think are especially important. It doesn't mean the other slides are not important, but the ones with the red stars are really kind of the take-home messages. And another way of thinking about it, not all diabetics need an endocrinologist, right? Not all CKD patients need a nephrologist. And we're kind of at this stage where we're not educating people well enough what to do, when to panic, and when to kind of stay cool and to follow their patients in the office or in the hospital. That's what this talk is going to help to correct. So before we get going too in depth, everybody hates anatomy pictures, I just want to review what we're talking about when we're talking about kidneys and filtering. About 5% of the entire anatomy of the kidney, the entire geography of the kidney, are these little tiny blood vessels, balls of blood vessels that we call glomeruli. The top, they look like little cherries on a tree, connected with a tubule where the urine that's made by the glomeruli is thereafter modified and adjusted. The bottom left panel shows that there is an afferent arteriole, an in, and an efferent arteriole, an out, and that this ball of capillaries, about the size of a hair, surrounded by a capsule is where urine is made. Differences in the in and out blood vessel create pressure there, and that pressure, like wringing a washcloth, makes the urine form within the capsule, and then it goes into the tubule to be fixed. We're each born with about 1 million glomeruli in each kidney. You get what you get, and you don't get any more. You don't form any more, you just have to take care of the ones you have. And if you start losing them, then the 1 million in each kidney, if they become 800,000, 500,000, they have to do the work of the original 1 million. And if you are taking care of somebody who's born profoundly premature, they won't have the entire 1 million. They may have 500,000 when they're children. It's kind of like taking a cake out of the oven too early. It's not done baking. If you are born profoundly premature, you'll never develop all the glomeruli that you need. And perhaps the most important aspect is you get 1 million in each kidney, they decline with age, and aging is the number one thing that reduces the filtering glomeruli. So let's go to the 1, 2, 3 of CKD. And basically, these are the 3 steps to evaluate and manage patients with CKD. Number 1, GFR. The staging criteria put together decades ago looks at GFR, and they determine it to be either normal or low. At the very bottom, less than 15%, we consider kidney failure. Less than 15% means a patient may demonstrate symptoms of uremia that require a transplant or dialysis. Doesn't mean that when you trip over and are below 15%, you need dialysis. We take care of many people with GFR below 15% who don't need dialysis. The average GFR in America of starting dialysis is around 10 to 11%. There are kidney doctors out there that will start people on dialysis if they're less than 15%, but you've got to really have symptoms of needing dialysis. In essence, anything below 60%, we call that stage 3A and B, places a patient at risk for GFR decline. And if you notice up above, this is originally from the NIH and NKF working group. And again, this was stimulated decades ago because the NIH started to panic and said, dialysis is costing so much money, we're not going to have as much research money. You guys got to do something about this. And so this criteria was developed. And the whole idea is to identify and treat people early before they get to stage 5. When we look at GFR, we have to ask ourselves, what do we measure? And everybody's used to measuring creatinine. That's what we look at, creatinine. Creatinine is generated by skeletal muscle. Many people don't remember that. And so the skeletal muscle of your patient will vary compared to other patients, and it will vary within their lifespan. You'll have some big, robust people that towards the end of their lifespan or due to illness will lose their creatinine generation. That's what makes this so difficult, because when we look at creatinine and GFR, we're comparing apples to oranges many times. So another compound called cystatin C has been looked at, and cystatin C at one time was thought to be the holy grail because it is generated from nucleated cells. Every nucleated cell of the body generates this. So in theory, it bypasses the muscle mass issue. But unfortunately, we now know that cystatin C, if you take a look at the lower panel, is affected by inflammation and infection and obesity and diabetes and thyroid disease, so it's not a perfect entity. Creatinine is affected by muscle mass. So they each have their own weaknesses, and right now we're using creatinine. But I'm putting the slide out there because eventually cystatin C is going to be used more and more, and there are hybrid mathematical models that are going to say, okay, let's measure creatinine and cystatin, and we'll put a GFR calculator together on that. So look for that in the future. And then when we look at creatinine or cystatin, we have to ask ourselves, how do we measure it? So all equations use either creatinine or cystatin, your age, your gender, and or your race. And so there's 2 prominently used mathematical equations. And those of you at this hospital in particular are probably scratching your head because often GFRs from both equations are being published. Your use, if you've been around the block for a few years, you realize that the MDRD equation. MDRD is the Modification of Diet and Renal Disease trial, which is in the 1990s, where we measured creatinine and we very, very intensely with a research mechanism measured filtering rate of the kidney. We built this mathematical equation and we realized that African Americans will make more creatinine per pound of muscle, per pound of weight than all other racial groups. And so there's a difference in your GFR. Are you non-African American or African American? And many of us are used to seeing that. That was thought to be putting too much emphasis on race. There's probably, I think, a little bit of a political bent to that. And so A newer equation is developed called the EPI calculator. So we're now seeing the MDRD equation as well as the EPI equation. And the EPI is thought to be the one to use. It is a race-neutral equation. And I think there's some health in that. But you should know that if you're not African American, it's going to overestimate your GFR by a little bit. And if you're African American, it's going to underestimate your GFR a little bit. And that's where a lot of the specialists in my area are concerned that we may be thinking that somebody's at stage 5 because of their African heritage, when in reality, their GFR is a little bit better than that. I want to emphasize, and I see this all the time, that CKD stage 3 or 4 or 5, it's not a disease. People say, oh, they have CKD stage 3. Because of why? We have to find out why. Why are they at chronic kidney? CKD is just a spectrum of health to disease. It's just a measurement. But we have to ask ourselves why. We have to have a diagnosis. CKD is not a diagnosis. Is it CKD because of diabetes or lupus or polycystic kidney disease or transplant rejection, et cetera? And why is that important? Because they all have their own natural course of GFR loss. They have their own natural history that we have to pay attention to. Loss of GFR occurs with aging. So when you look at the algorithm, there's a tremendous reduction in GFR every age that we are after the age of 40. We lose in general about 1 ml per minute, about 1% kidney function every year after the age of 40. So by definition, a 90-year-old will have a GFR of 50 milliliters per minute, which begs the question, do they have chronic kidney disease, or is this just age-adjusted normal? It's a constant battle that we deal with taking care of elderly patients. In fact, the most common cause of GFR loss you'll see in the office is aging. So look at your patient, look at the GFR, and try to say, is this really relevant? Is it relevant that a 75-year-old has a GFR of 55? Is it really that big of a deal? We'll talk more about that in a minute. The eGFR, I jokingly tell residents and patients, medical students, the little e should be a capital E, italicized, bolded, underlined, because the E is an estimate, and we forget it's an estimate. It's an estimate only. Muscle mass varies between patients. This is a screening tool. This is not the end measurement. And if we really want to know what somebody's kidney function is, we don't estimate it, we actually directly measure with a 24-hour urine collection, which by and large are still not accurate, and depending on who your patient is, sometimes incompletely collected, but they're still better than the estimate. And what I'm about to show you on the slide is the emperor's clothes slide. Hopefully you know what that cliche means. And by that, I want to explain to you that all the estimated GFR is doing is showing you on a bell-shaped curve the median GFR. Okay, so they take a population, and you are all used to the bell-shaped curve, and the mean, which is right in the middle of that, is what the number is you're going to get. And if a patient's within 1 standard deviation of that, about 68% of patients will be captured in that. But we have patients who are within 2 standard deviations or 3 standard deviations of that number because of their muscle mass, whether that is excessive muscle mass or withered low muscle mass. And so when we look at that mean GFR and think that that's exactly what the patient's kidney function is, we sometimes are very, very wrong. And this is a crazy busy slide. I'm going to take a couple of minutes with it. I don't want you to freak out, and I want you to notice the red star. I want you to come back to this and take a look, because this was published just a year ago, Annals of Internal Medicine. Huge 3,000 patient trial, and they measured on the y-axis, they measured kidney function very accurately, and on the x-axis, they used the MDRD equation in this to estimate filtering rate. And then you'll see patients on the far left, filtering rate of 15% estimate, all the way up to 60%, all the way up to 90%. And each one of these scattergrams, you'll see a black box. That black box is the median or the mean. That's the number you're going to get on the lab. Okay? So when your GFR looks like it's 15, I'm going to go to the far left, the measured GFR for most of those patients is a little better at 18%. But in this group of individuals who it says the estimated GFR is 15, patients were as low as 7% when they measured and as high as 37% to get 97% of the patients. So what it shows you is 1 standard deviation, 2 standard deviations, 3 standard deviations of patients. So even within 1 standard deviation, your patients may be up in the 20s, even though the estimated GFR is 15. Look on the far right side. Black box, 86% measured filtering rate. Okay, when you think their estimated GFR is 90, it can be as low as 56 if the patient doesn't have muscle mass, or it can be as high as 120 milliliters per minute if they have muscle mass. Basically, this is the emperor's clothes. The emperor has no clothes. How do we use the estimated GFR to really know what the patient's kidney function is? Well, first of all, we look at trends. Trends are important, so it does help us. But you look at the patient, look at the muscle mass. Are they average? Are they below average? Are they above average? And then we do a 24-hour urine collection to compare and contrast. So I just want you to know it's not all chiseled in stone. Estimated GFR is accurate for normal size, gender, and age. When muscle mass is greater than normal or less, 24-hour urine collections. Trends, as I mentioned, are helpful. And I'm going to throw out here one little thing you should watch for. Fenofibrate. This is a triglyceride-lowering medication. For some reason, this medication stimulates the muscle of our body to make more creatinine. Does not affect filtering rate of the kidney. Doesn't affect the kidney at all. But it makes the muscle make more creatinine. So if more creatinine elevates your blood creatinine level, the lab's going to say your GFR has fallen. So our patients on fenofibrate for a long time, we do 24-hour urines because we'll see usually the creatinine clearance, the GFR, much higher than the estimate GFR. Don't stop the fenofibrate. It's not hurting the kidney, but it does cause this kind of lab abnormality. I'm not going to read through these. These are just for you to review. There's 2 examples of underestimating and overestimating GFR, comparing them to 24-hour urines. Step 1 is GFR. Step 2 are urine studies. Makes sense. Kidneys and urine make sense. Can't tell you how many times patients with CKD have never had a simple urine study done in the hospital or in the office. Okay? 2 urine studies, urinalysis and measuring protein, in particular albumin in the urine. Why do we care about the urinalysis? Obviously, we like to see if there's dipstick positive protein. But the main thing we're looking for is hematuria, microscopic hematuria. Because microscopic hematuria, if your GFR is low, may represent a glomerulonephritis, a very rapidly progressing inflammatory disease of the kidney. ANCA-vasculitis, IgA nephritis, lupus nephritis, a disease called MPGN, lots of nephritis, has microscopic hematuria. So we like to see if a patient has that. We like you in the office or in the hospital to get a UA and see if there's hematuria. And we want to make sure, first of all, that it's independent of infection. If there's a bladder infection going on, treat the bladder infection, repeat. And even if you get it, some microhematuria, and there's not a bladder infection going on, repeat it. Let's see if this is chronic and recurrent microhematuria. If so, we're going to go to some kidney imaging, which is step 3 of the 1, 2, 3. And we're going to ask ourselves, what's doing this? And we're also going to ask for nephrology help. Long list here. I'm not going to go through everything of when to refer to urology and when to refer to nephrology if your patient has hematuria. And it makes sense if there's risk factors. I've been smoking all my life. I've had radiation to my bladder. I've had gross hematuria. That's urology's wheelhouse. Send to urology. Because if you send them to our practice, other nephrologists' practice, we're going to send them to urology. Nephrology, we like to see if the GFR is low, if there's microhematuria with proteinuria. young people, no risk factors like smoking and bladder cancer, et cetera. It's all here. I'm not going to go through it in exorbitant detail. But please know that there's a difference between referring to urology and nephrology. The other reason to get a urinalysis is just to look for protein. And the dipstick urine, when it says protein, it's really measuring albumin. It's not measuring other types of proteins. And when you see this, I want to emphasize to you that there are so many anatomical barriers of the kidney to prevent blood in the albumin in the bloodstream from leaking into the urine, that when we see this, we know there's a whole lot of problems going on within the glomerulus. Albuminuria represents a breakdown of these barriers. And as we're going to emphasize throughout the rest of this talk, protein leak will cause lots of other downstream events, and it will lead to eventual total kidney failure. We'll talk more about that in a second. Crazy diagram, but this is just to kind of illustrate in your mind what happens within the glomerulus. This is a capillary of the glomerulus sliced in half, and at the very bottom is the lumen, the lumen of the capillary with arrows that show for albumin to get from the capillary outside of the capillary into the urine, they have to go through an endothelial layer, a glomerular basement membrane layer, which by the way is negatively charged, and albumin's negatively charged. So like a magnet, they should be repelling albumin. And then these tombstone-looking structures are actually little finger projections of a cell called a podocyte. Look in the right upper corner, the diagram. The podocytes are like saran wrap around the glomerular capillary. They're like saran wrap around it, living, breathing cells that have these little finger-like projections that also prevent protein. And in between these little finger-like projections, these slit diaphragms, that's where filtering occurs. So all these structures have to fail if albumin's in the urine. And if you take a look, I'm going to put these little MR, mineralocorticoid receptors, are on those podocytes. And I'm going to come back to that because aldosterone directly affects these guys and girls and makes them really sick. So when we antagonize that, we help these entire structures. We'll come back to that in a minute. What we want to know is if there's albumin in the urine. Urinalysis is sensitive to albumin, not low molecular weight proteins. There's a lot of other proteins from the bladder and the tubules that might be in the urine. Unfortunately, the dipstick's only sensitive to about 300 milligrams of albumin a day. So if you're urinating a little less than that, you'll have a negative urine dipstick, but that still may be a pathologic condition. You may have too much, or your patient may have too much albumin in the urine, then the dipstick's negative. The urine's not standardized to how concentrated or dilute it is. So you could drink a lot of water and have a negative urine dipstick for protein. Or you can drink a little bit of water, have a really concentrated urine, and have a positive dipstick for protein. And radiocontrast dye, you got a CAT scan, it's going to concentrate the urine because of the dye. It's going to be a false positive protein. Pyridium, if you have a patient who has cystitis, bladder infection, pyridium will give you a false positive. And really high urine pH will give you a false positive. So know that there are false positives to the dipstick. And then again, the concept, as I just said, when we do a urine dipstick, it's a concentration box that we're trying to light up or not. But that's a concentration. And we do not know how well the patient's hydrated or dehydrated they are when we get it. So what we do, and this is something that really confuses our patients when they get their labs, what we do is we measure another chemical that's always in the urine at the same concentration, minute by minute, creatinine. We measure creatinine in the urine simultaneously with measuring protein because the concentration of the creatinine values are always the same. We excrete, filter creatinine at the same rate every minute of the day. It's emerging from our muscle at the same rate every minute of the day. The amount of creatinine in the urine is going to be the same. Its concentration, whether it be low or high, reflects how concentrated or dilute the urine is. So when we compare creatinine and protein together, we get a ratio. And that ratio is what we look at. That's a standardized ratio. And it just so happens that most of us make about 1,000 milligrams of creatinine a day. If we make about 1,000 milligrams of creatinine today, then the protein or albumin to creatinine ratio will give us an idea of how much protein our kidneys are leaking per day, as if we did a 24-hour collection and measured the protein. So we find this incredibly valuable. In the box at the bottom, a protein to creatinine ratio of 1 means you're peeing 1 gram a day. 4.5 means you're peeing 4.5 grams a day. If somebody's small or somebody's large, this may be over or underestimating it, and then a 24-hour urine is important. But that's why in so many of our patients in the hospital or in the office, we're looking at that ratio and we're comparing it to previous ratios, and we're getting worried or not worried depending on how much protein or albumin is in there. We take a look at the albumin and we actually divide that into categories as well. Again, a red star. This is very important for you all to know, for us all to follow. Albumin to creatinine ratios. Again, we're looking at the creatinine to standardize the amount of albumin, whether it's a dilute or a concentrated urine sample. There's a term called microalbuminuria, and there's a term called macro, large amount of albuminuria. The powers that be, the international powers that be, don't want us to use micro or macro anymore. They just want to talk about albuminuria, but we still know it this way, and we still order it through the lab this way. Microalbuminuria is albumin excretion less than 300 milligrams a day. Anything over 300 milligrams a day is macroalbumin, and that represents a big problem in the glomerulus, a big problem. So under microalbuminuria, now that is measured as either micrograms per milligram of creatinine or, same thing, milligrams of albumin to grams of creatinine, but they measure it as micrograms per milligram. It comes in 3 flavors. Less than 30 is totally normal. 30 and above is abnormal. So 30 to 300 we consider to be concerning, but I'm not gonna cry about it. I'm just gonna watch it. I'm gonna treat it. Or over 300, which is basically macroalbuminuria. Less than 30 normal. 30 to 300 we watch and we treat. Over 300 we panic a little bit. Okay. When we do this, when we see somebody who has albuminuria, the number one thing to do is not hit the panic button, but to ask yourselves, is this just temporary? Is there something going on here, or is this permanent? And of course, to say that means you have to do more work, and you have to say, okay, what's going on right now? Is there something going on to cause it, number one? And number two, let's repeat it in a few weeks or a month or so to see if it is permanent. And again, a red star here, pay attention. There are conditions that will transiently elevate the albumin leak. Again, we receive a lot of consults for albuminuria in patients who have reasons for the albuminuria, and if we control those reasons, they don't have albuminuria in reality. Very high blood pressures, really high blood sugars, infections, vaccinations, inflammation, can all do this. Well described. Somebody gets an influenza, I'm not even talking COVID, influenza vaccine, albuminuria. Little kids get their MMR, they get albuminuria. So the inflammation that occurs with a vaccination is enough to increase the albumin excretion. So look at your patient. If their A1C is 13%, don't look at the albuminuria at that time. If their systolic pressure is 180, don't get the albuminuria. Control the variables before you label a patient as having albuminuria. Of course, if you do everything right and the patient has a protein to creatinine ratio of greater than 3, we call that nephrotic range proteinuria. Nephrotic range proteinuria gives rise in many people to what we call the nephrotic syndrome, which is highlighted there. A lot of protein in the urine, so much that it drops your blood albumin level, it stimulates cholesterol buildup, it makes a patient hypercoagulable. So nephrotic syndrome causes a dramatic increase in cardiovascular disease rates. Hypercoagulability will occur in these individuals, particularly if they have any of these issues. And so sometimes we'll have to start preventive therapy, anticoagulation for these folks. I'll let you read about that a little bit later. So I just mentioned albumin and protein, and some of you are saying, wait, what am I supposed to do? Do I measure protein? Do I measure albumin in the urine? What do I measure? So if we're thinking about early kidney problems, early chronic kidney disease, urinalysis doesn't show massive amounts of proteinuria, we look at albumin. So albuminuria looks at the glomerulus. That diagram that I showed you, all those barriers being failing basically, we look for albuminuria. But when albuminuria, proteinuria is excessive and massive, the lab assay to quantitate that falls apart. And if you order somebody who has massive amount of albuminuria, sometimes the lab will say it's really high. It's greater than 1,500. So sometimes it's difficult to quantitate, and the labs will just say it's so high, it's beyond our albumin scale. And in that situation, we say, let's look at total protein to creatinine ratio. If you look at protein to creatinine ratio when there's only a little bit of albumin, those other proteins I talked about from the bladder or from the tubules, they'll be there, and sometimes they give you a little bit of a scare. There may be more of these non-albumin proteins when there's not a lot of albumin than there is albumin. But when you have massive amounts of albumin, the contribution of those other low molecular weight proteins is so minimal that it's still pretty accurate. So early, get albumin to creatinine ratio. If it's massive, we look at protein to creatinine ratios. I'm going to give you a little aside here. I want to emphasize this point. Proteinuria is a risk factor for losing kidney function. Very busy slide here, but I'm going to walk it through very quickly. For 30 years, we've known about proteinuria being associated with the kidneys failing. 2 studies I just mentioned throughout this talk, the MDRD equation. Well, the MDRD, the modification of diet and renal disease trial in the 1990s, and then below that, REIN, that's a ramipril study. Ramipril is an allopril. That used to be the hot kid on the block a long time ago before lisinopril. The ramipril trial, both of these trials ask the question, what happens to patients who have a lot of protein in the urine, and what's the natural progression of kidney failure in those individuals? Staggeringly, before the 1990s, nobody put 2 and 2 together. People had a lot of protein in the urine, and they went to dialysis very quickly, and docs used to say, well, they were sick. The sicker you are, the sicker you are. It just happens. We now know that the amount of protein leaking dramatically affects the rate that you lose kidney function. So if you look at the far right on the MDRD trial and the far right of the RHINE trial, baseline proteinuria in the MDRD greater than 3 grams a day, nephrotic. GFR decline 8% per year, 8% per year. Look at the RHINE trial, far right-hand corner, baseline proteinuria greater than 4.5 grams per day. The rate of kidney function loss, almost 10% per year. So your GFR can drop from relatively normal to less than 15% needing dialysis in 5 to 6 years. And when my partners and I were young guys, we used to actually would say maybe to a 30-year-old type 1 diabetic, yeah, you've got a lot of protein in your urine and you're going to be on dialysis in 6 years. And that would be almost a statement of fact. So this kind of woke us up to, this is a big issue and we got to do something about it. And the ASK trial, this is a diagram from the ASK trial, basically was one of the first that said, well, wait a minute, if you reduce the protein leak, medications, then maybe we can improve things. So at the very bottom of, the very middle of this slide, change in proteinuria. If your proteinuria doesn't really change, the relative risk is pretty much even. We're comparing changes increasing or decreasing protein leak to what happens to needing dialysis. And if you take a look to the right, anytime that you increase the proteinuria on the far right, when you double, 100% increase in proteinuria, your relative risk of needing dialysis in a few years doubles. Relative risk goes from 1 to 2, doubles. On the flip side, if you reduce albuminuria, proteinuria, and you go down greater than 50% reduction, you can go down to maybe 75% reduction in the likelihood of needing dialysis. There's like a light bulb effect. If we do the right thing, we can slow this down. Because of the role of albuminuria, I'm going to see if the circle comes up, that standard CKD staging criteria that we're used to, stage 1, 2, 3A, 3B, 4, has now been modified to include A1, A2, A3. Albuminuria, A1, A2, A3. Albuminuria, normal, less than 30 is 1, 30 to 300 is 2, greater than 300 is 3. So you'll see in red, the red boxes represent very high risk of progressing to end-stage renal disease. And if you take a look at this, there's a dramatic role of protein leak affecting the rate that people will lose kidney function. And we print this up. I give this to patients. A lot of hard-headed people out there, and I say, look, this is where you are. This is where you are with the protein. If we don't do things better, we're in trouble. But if we do things better, we can go from the red box to a lighter colored box and help you out. And those of you who are primary care providers, this is very available. I would use this as a teaching tool in the office, just to kind of bring people to some realization of where they are. Step 3, so we went through step 1 and 2. Step 3 is imaging. So in your office, in the hospital, measure GFR, urinalysis, albumin to creatinine ratio, now imaging. We're going to ask you to do some imaging up front. Don't send to our offices, don't wait for this to happen. As you know, in some hospitals, including our hospital, it may take several weeks, a month or so, 2 months, to get all the imaging done. So try to do that early, kind of prime the pump a little bit. And the imaging we want are ultrasounds and sometimes CAT scans and MRIs, and we'll go through this really quickly. Very, very big slide here. But we prefer ultrasounds because CAT scans do not measure the top to the bottom of the kidney. We want to see the top of the kidney and the bottom of the kidney and measure the size. Anything less than 10 centimeters is typically atrophy, wear and tear on the kidney. So it's nice to know if you're a patient who has CKD, if their kidneys, instead of being 12 or 13 centimeters, are 8. 8 means they've been ridden hard, high blood pressure, analgesics, whatever. They're atrophic. They have really burned out kidneys. The thickness of the cortex, the glomeruli in the cortex of the kidney, the normal cortex should be greater than 1.5 centimeters. If they're below 1.5 centimeters, again, wear and tear. Can't do anything about that, just can preserve what you've got from getting worse. And then polycystic kidney disease. You'll be amazed how many people, when you're seeing them in the office, you'll say, well, do you have a family history of any kidney problems? No, no family history. GFR is a little low. You'll get an ultrasound, and they have polycystic kidneys. 25% of PKD, polycystic kidney disease patients, don't have a strong family history. They are a spontaneous mutation causing the cysts. And if you have them, I want to see them early. My partners and I and all nephrologists want to see them early because there are things we can do to try to slow the rate of cyst growth and kidney function loss. So we want to see them very, very early, even if they're not at CKD. Let's say that their mom or dad have PKD and they want to know, they get an ultrasound. So even in that situation, we want to see them. The ultrasound also shows, are there things your urologist should see versus us? And that's stones, masses, severe hydronephrosis, even mild hydronephrosis. If a radiologist says mild hydronephrosis, mild obstruction is present, it's not mild to the patient. It's probably causing a problem urology needs to see. Second step, if that happens, masses, stones, hydronephrosis, is to get a CT and see what's going on. And most of the time, the radiologist will guide you what to do. Many times you'll get an ultrasound and you'll see the patient has a cyst. And many of your radiologists will describe it as a Bosniak cyst. This is the Bosniak criteria. Okay, and we class 1, 2, 2F, 3, and 4. And I want you to know about this because a cyst, by and large, by itself, or even numerous cysts that are simple cysts, are a so what phenomenon. If you take a look, the the features and you look to the right of that, the workup. If you have a simple cyst, there is no workup. No, nothing. No workup. Common. As you get older, cysts develop. It's like wrinkles and gray hair. Cysts develop as we get older. The likelihood of malignancy, none. Even a minimally complex cyst is typically no further workup, low malignancy. Bosniak 2F has some density to the cyst, some calcification of the cyst, and those, most of the time, the radiologist will say if it's 2F, you need to repeat CT imaging and then have them back every 4 to 6 months to keep repeating. 3 and 4, basically high risk of malignancy. You need a urologist. We got to do a partial nephrectomy, biopsy, something to keep the patient from having a more advanced malignancy. So just a partial summary, again, little red star. KDIGO asks if you're a primary care provider to do these 3 steps, the 1, 2, 3. And I know it's a lot of work, but if you have somebody who has relatively preserved GFR, stage 3A, not a lot of albuminuria, acceptable kidney imaging, things look good, especially if they're over the age of 45, they don't have urinalysis that shows hematuria, to just say, you know, things look good. We're going to measure your kidney function every 4 to 6 months. We're going to measure the albumin in the urine, but you're probably going to be fine. It doesn't mean that you don't treat high blood pressure and other risk factors. Obviously, diabetes, hypertension, all those risk factors need to be watched. But if all of this looks fine, a nephrology referral really isn't needed. And most of the time, we're going to tell you nothing else is needed. I'm not going to see them in follow-up. You can follow them on your own. But if anything else differs from that, particularly even if your GFR is below 60, and this is a little bit of a National Kidney Foundation personal opinion, if your GFR is below 60%, you're at stage 3A, but you're young, you know, less than 45, you're 30 or 35 years old, you might want to look into why that is and refer. Because I don't want to see a 35-year-old who has a GFR of 55 and expect them to live another 60 years with such low kidney function. That's the wrinkle. Now, as I told you earlier, there's a handout that's there, you don't have to read it right now, that have different patient scenarios to try to emphasize this point for you. You'll get this in the office, I get this in the office all the time. Doc, my sister's on dialysis. I'm worried about my creatinine at 1.3. How close am I to dialysis? We spend lots of time telling patients, you're fine, you're fine, you're fine. But I just think I'm going to be on dialysis someday. Nothing convinces people as well as a number, a percent. So what has been developed years ago is a kidney failure risk estimator. And I want you to know about this. It's available on the bottom on lots of medical apps. You can download this. It's very easy to use. Your age, gender, the GFR, and the albumin to creatinine ratio is all you need on your patient to give an estimate, 2-year and 5-year estimate of a patient needing dialysis in the future. In the red, 75-year-old with a creatinine 1.6, GFR 45, albumin 55. You crunch the numbers. You tell them, don't worry, you're not going to need dialysis. You crunch the numbers and tell them, in fact, your 5-year risk is 2.4% of needing dialysis. Well, that doesn't sound very bad. I'm happy. That sounds great. Now I can sleep at night. Or sometimes you have to use this to kind of kick people in the butt and get them going. So a 45-year-old with a high creatinine, low GFR, and a whole lot of albuminuria, you crunch the numbers, their 5-year risk is 41%. Say, look, if we don't do something differently, you've got a big likelihood of needing dialysis soon, not just an opinion. This is what the numbers say. So we use this quite a bit, and you can use this quite a bit as well in your office or in the hospital. I'm going to take a little bit of a divergence in the talk and emphasize something that's probably going to be even more relevant to you as a group. I know there are PCPs, but there are also specialists out there as well. Chronic kidney disease is a cardiovascular risk. And if you look at the staging, stage 1, 2, 3A, 3B, stage 4, all the way to dialysis, you look at the United States population, we have 15 million at stage 3, but we have only 750,000 at stage 5. 15 million ends up with 750,000. Okay? Where'd they go? Well, they died of cardiovascular disease. The annual cardiovascular disease risk is 5 times the risk of losing GFR. 5 times the risk. So our patients with CKD, many don't make it to dialysis because they die prior to that. This is a quick little shot from a New England Journal of Medicine article 20 years ago that demonstrated this point and kind of woke everybody up. This is from the Kaiser Permanente medical system out in California. 1 million patients, 1.1 million patients. They just took a look and they said, okay, we have a problem. We think we have a problem with cardiovascular disease. Let's take a look. On the y-axis, age standardized cardiovascular rate, events per 100 patients, or events per 100. Okay, lives, 100 years, 100 lives per 100. And on the bottom, you'll see the GFR, normal all the way to less than 15% dialysis. Look at the dialysis population. For every 100 patients, 36, 37 cardiovascular events. It's an epidemic, and you've seen this. You see it in the office, you see it in the hospital. Cardiovascular disease is very prominent with chronic kidney disease. And then to add to that, proteinuria adds to that cardiovascular risk score, dramatically adds to it. And why is this? I showed you that capillary cross-section, all the structures that have to fail to get protein in the urine. Those are the same structures that are in all the other blood vessels except for the podocytes. The internal blood vessels are damaged globally in many patients, diabetics, inflammatory disease. So the heart and the rest of the vasculature is diseased. We see it in the kidney. It's the tip of the iceberg. It's the tip of the iceberg. Back when losartan trials first started, they went to say, okay, can we reduce protein in the urine for type 2 diabetics? Kind of a cumbersome slide. The top shows the percent with cardiovascular endpoints. The bottom slide, the bottom diagram is basically the risk, relative risk. Remember, relative risk of 1 is neutral, a 2 is a doubling, and you'll see that with increasing amounts of albuminuria, the number of cardiovascular events starts going up. Proteinuria causes cardiovascular events. This is the losartan trial from years ago, 20 years ago. And this is one of the first trials that said, hey guys, girls, if we reduce this, we may help people. We may help reduce cardiovascular disease. And if you take a look at albuminuria reduction for cardiovascular endpoints, heart attacks and stroke, and you look at heart failure risks, by reducing albuminuria, reducing proteinuria, you can dramatically decrease the risk of cardiovascular events and heart failure. And in fact, every 50% reduction in proteinuria reduced cardiovascular risk 18% and a 27% reduction in heart failure. And in this trial, proteinuria reduction was the strongest predictor of cardiovascular events. Proteinuria reduction not only is important to nephrologists, it's important to primary care providers, it's important to vascular disease docs, it's important to cardiologists. The wake-up call is, because we know of all this, the greater the proteinuria, the greater the risk. Reducing proteinuria, the lower the risk. Screen often, screen aggressively, try to lower it. One study showed that only 30% of primary care offices ever test for proteinuria or albuminuria, even a urinalysis. It's a wake-up call. We have to do a better job of screening our patients with a urinalysis and an albumin to creatinine ratio. How do we reduce the cardiovascular risk? CKD in general is a cardiovascular risk, and proteinuria increases that. This is standard care. tight blood pressure control. The SPRINT trial, recently published, not too long ago, showed we really should target systolic pressure less than 120 in our very high-risk patients. 120 in our high-risk patients. Aggressive proteinuria control and reduction in statins. Chronic kidney disease, risk factor for cardiovascular disease, think of statins. Statin therapy in CKD3 and higher. I will tell you, I'm not great at this in the office. I will tell you, endocrinologists, cardiologists, lots of us are not great at this. But the American College of Cardiology, American Heart Association recommends statins for CKD. If you're greater than 50, you need a statin. If you're less than 50, you need a statin. If you're at a high cardiovascular disease risk, you're diabetic, advanced chronic kidney disease. And the pharmacology of this is if you have just a mild GFR loss, maybe 3, early 4, use a low to moderate dose statin. Higher CKD stages, moderate dose statin, but do not crank up your statins to super high levels. I know people love to do that, but the side effects from the statin are associated with GFR, and patients will sometimes feel very miserable on that. So go to maybe a moderate, like a Lipitor of 40, and then add Zetia to that combination. That's kind of the recommendation. All CKD, and there's many CKD patients walking around that are not even near on any of these medications at all. Okay, said a lot. I've got more to say. We're going to switch right now, take a deep breath, and talk about screening and management of chronic kidney disease. What can you do in your office? What can we do in the hospital? KDIGO, our friends KDIGO, way back in 2014, basically we screen all chronic kidney disease patients for that annually. And if there's something abnormal, GFR or whatever, maybe twice. And there's a little correction factor that came out a year later in 2015 that if your age is high, if there's a family history of kidney problems, and if you're African American, Native American, Hispanic, obese, have a cardiovascular risk, to do it more aggressively. So a lot of people fit this criteria, and they never have a GFR measured. So measure GFR. Diabetics, looking for albuminuria. Type 1 diabetics, after about 5 years of diabetes, you should start screening. Type 2, because we don't know how long a patient's been hyperglycemic, at the onset of high A1C measurement, you get an albumin to creatinine ratio, okay? I've had family members of mine who have a high A1C, and they've never given an albumin urine sample for their docs after even years. Not even on onset, but after years. We miss this all the time. PCPs are expected to do this. You're expected to look for albuminuria. And if it's present, you're expected to act on it. How do you treat it? Makes sense, lifestyle management, pharmacotherapy. Optimal A1C, optimal BMI, and here is the new holy grail of cardiovascular disease in general, weight reduction. Do you do surgery or do you jump on the GLP-1 agonist bandwagon? There are more and more GLP-1 agonist pill form, injection form coming out, higher doses. Some of them are showing after a year an 8 to 12% reduction in weight for obesity. That's as good as a gastric sleeve surgery. Not quite as good as a bypass, but really close to it. And there's a lot of patients who fail the sleeve or gastric bypass that you can put on a GLP-1 and you'll get even a more aggressive 20% body weight loss or more with this therapy. And then the SGLT2 inhibitors, Jardiance and Vicana Farxiga, they also help lose weight. So why not lose weight, improve glucose, improve blood pressures, improve cardiovascular, and improve albuminuria with those medicines? Sodium intake, we like it to be low. Hard to follow 2 grams, at least less than 4 grams would be great. If there's a lot of albumin in the urine, we try to dietary restrict protein. Most people are probably less than a gram. We don't want them to be 1.2 grams per kilogram per day. There's a way of checking that. in 24-hour urines. I'm not going to go into detail, but you can recheck a patient, kind of do a spot check on a 24-hour urine. And then, as we mentioned, tight blood pressure control. What do you choose for blood pressure control? As I just mentioned, the SPRINT trial, which stimulated K-digo to say a systolic less than 120, suggests that we really have to be aggressive, and it's not going to take 1 or 2 medicines. It's going to take maybe 3 or 4 medicines to achieve blood pressure goal. This is a list of antiproteinuric medications, ACE inhibitors, ARB, MRA agonists, et cetera, that we can use. Remember, blood pressure combinations are very, very important, but try not to start patients on the dihydropyridine calcium channel blockers, amlodipine, nifedipine, et cetera, or minoxidil. We will use those in combination with the other ones if blood pressures are resistant, but those other medicines under the avoid category increase proteinuria, increase your protein leak. And of course, that's working backwards. Going back into a system, renin-angiotensin-aldosterone system, you should all know it very well. We all try to block angiotensin II, the third guy down, which is the bad boy. Angiotensin II causes vasoconstriction. It destroys blood vessels, causes sodium retention. It creates aldosterone, which then creates sodium and water retention. It causes scarring, fibrosis, and then we try to stimulate or we try to prevent the production of aldosterone, which does some of the same things, including fibrosis. And so this is the pathway that most of our targets are, either through an ACE inhibitor, an angiotensin receptor blocker, or anti-aldosterone therapy. I'm going to spend a couple of minutes talking about aldosterone because it's become the new kid on the block to start to beat up, and for good reason. Look at the branch point. To the left is what we always thought of aldosterone. At the kidney cell, we know aldosterone makes sodium retention, volume expansion, high blood pressure, and low potassium. We've known about this for decades and decades. But there are other cells that are responsive to aldosterone. If you remember that capillary diagram I showed you, that cross section, the podocytes, the finger-like projections, I showed you little shields that had MR, mineralocorticoid receptors. Those cells are chock full of receptors for aldosterone. Now, why is that? They have nothing to do with sodium and water. Why is that? It just so happens mineralocorticoid receptors are there. They're in the heart. They're in blood vessels. They modify heart tissue, blood vessel tissue. They modify the glomerulus. And so too much aldosterone is a bad thing. So in other vascular entities, it causes vasoconstriction, high blood pressure, proteinuria, scar tissue, so we should block them. To the right, common mineralocorticoid receptor blockers, spironolactone, Inspra, and the new kid on the block, finerenone, which is Kerendia. Spironolactone in males can cause gynecomastia, painful breast. If you start it, even low dose, tell your male patients that this is a risk. They're not going to tell you that they're having these side effects. They're not going to tell anybody. They're going to be very embarrassed. Tell them it can happen, and tell them if it happens to let you know to convert to Inspra. Finerenone is being strongly marketed in the community by the reps that it is really great for chronic kidney disease and proteinuria, and it really does have a great role in proteinuria and chronic kidney disease. But it's cheaper, it's more expensive than the other ones, considerably more. It does not lower blood pressure. It does not address edema like the other aldosterone antagonists. It does a little, but not like the other ones. So if you have a patient who has proteinuria and has these risk factors and their edematous and their blood pressures are high, use one of the other agents, in my opinion. I draw this diagram to every resident and every student I work with, and I'm drawing the diagram for you because I want you to know this is the background of almost all nephrology in the hospital or outside of the hospital. And this is the way the glomerulus works, okay? And I showed you this in a diagram earlier, and I'm sorry to kind of belabor this, but the glomerulus, this group of little blood vessels, capillaries that are within the membrane, they don't work. They don't filter unless they have a pressure. There's no little battery in there that makes them filter. They filter depending on pressure differences, pressure going in, pressure going out. It's kind of like a garden hose. So the afferent or the intake has to dilate, the efferent has to constrict in order to maintain pressure. Now, all the acute kidney injury that occurs during the hospital, we always think, is this being screwed up? Did somebody lessen the output, tighten the input, and drop the pressure within that little ball of blood vessels? Is that why the creatinine went from 1 to 3? But in practice, walking around, patients who have chronic kidney disease, diabetes, hypertension, have this physiology at a very abnormal degree, where that angiotensin and aldosterone, look on the right side there, are constricting that efferent down so tightly that the pressure in the glomerulus is so high that it's squeezing a lot of protein out, making the proteinuria worse, and it's working the glomerulus to a very high rate, which over years and decades is going to make that glomerulus die, fail, like if you were running your car engine at 10,000 RPMs. So this physiology is in a lot of patients walking around. The afferent's dilated, the efferent's tight. So that hyperfiltration injury is what we try to antagonize. Lessening angiotensin and aldosterone, the right lower box, lessens protein leak, drops GFR, but that is sometimes okay. The creatinine goes from 1 to 1.5. Sometimes that's okay because we know we're doing the right thing by lessening the pressure. So to lessen albuminuria, here's some tricks of the trade. Okay, this is from practice, from our experience. ACE inhibitor or ARB, which one do I use? Doesn't really matter, except African Americans tend to have more angioedema with ACE inhibitor. I stay away from it. I use losartan or another ARB. Chinese Americans, more cough with an ACE inhibitor. Low salt diets. If you're on an ACE inhibitor and an ARB and you're eating at Wendy's or McDonald's every day in a high salt diet, you're totally negating all the beneficial effects of those medicines. That's why diuretics are so helpful with these medicines. Add spironolactone or another MRA to potentiate, to improve the effects of the ACE inhibitor and ARB. If you add aldactone or Inspro or even finerenone to an ACE inhibitor or ARB, proteinuria can be reduced 30 or 40, sometimes 50% more, which is great. Diabetics, even if their GFR is normal, if they have albuminuria, they need an ACE inhibitor or ARB, low dose, maybe at night. Because remember on that diagram, angiotensin and aldosterone, they cause scarring. They cause fibrosis in the kidney, in the heart, in the retina. So I joke that it should be in the drinking water. If you're diabetic and you have this risk, even if your GFR is fine, think about it. And then don't use an ACE inhibitor and ARB together because it can cause high potassium. Be patient when you use these medicines. It'll take up to 6 months to reduce the proteinuria. There's a type of medicine out there that inhibits renin. So you may think, I'm going to go way upstream and high. It doesn't really benefit that much. What about Entresto? Only the ARB of Entresto really works. And then vitamin D. If you're vitamin D deficient, adding vitamin D to your therapy drops renin and helps angiotensin levels be lower and can be antiproteinuric as well. So sometimes we forget to look at vitamin D levels. When we do all this, remember that diagram, the hyperfiltration, the pressure in the glomerulus? When we use these medicines to drop the pressure there, the abnormally high pressure, we don't measure the pressure, we just suspect it's abnormally high, GFR is going to drop. If we do nothing, look at the red line, a patient's going to be on dialysis. They're going to lose GFR and they're going to be on dialysis. But if you can antagonize this physiology, you'll lose kidney function early. Creatinine's going to go up a little bit, but the slope thereafter is going to be so much healthier that it's going to be better in the long term. And then many of you are going to say, well, I've got a patient who's got albuminuria. Many of my colleagues, we talk about this, they have albuminuria. How do I know that I'm helping them? We're giving what we can, but it's still there. If you can reduce albuminuria just by 30% by 6 months, you will dramatically improve future GFR loss, and you'll actually dramatically improve cardiovascular risks. So even a little bit has great, great ramifications. New kid on the block, SGLT2 inhibitors, just a couple words and then we'll be done. They reduce the hyperfiltration, and it's a really cool physiology for nephrology geeks. I'm not going to tell you the whole step-by-step mechanisms, but there's a handout that's printed up in front of you that goes through it. Please don't look at it now. That goes through the physiology of how these work to cause sodium loss, glucose loss, decreased GFR, and renal protection. They act like a diuretic. They improve all these things, cardiovascular, et cetera, but they act like a diuretic. So caveats of use, so when I start one of these, I drop an ACE inhibitor or ARB dose a lot, and I drop the diuretics maybe by half, because I don't want to drop the patient's blood pressure and collapse them. Nothing worse than starting them on that, have them drop their pressure, collapse, go to the ER, they'll never use the medicine again. So just be cautious, and then you can tiptoe back and add the therapy. Just like with an ACE or ARB, ACE inhibitor or ARB, when you add this to an ACE and ARB, you're gonna drop GFR further. Okay, it's not a reason to stop, it's not a reason to panic. This is the Invokana trial from years ago, New England Journal of Medicine. Again, GFR slope showing placebo, which is ACE inhibitor and ARBs, and then adding to that Invokana and how you lose GFR quickly, but then you maintain GFR thereafter. So it's a great addition. It's a great tool to have in the toolbox. Last slide on this, very, very detailed, but this is probably the best take-home message I can give you about this class. If you take a look at the far left, this is a study that looked at people who are an ACE inhibitor or ARB, and then the patients were added to that Forxiga or Invokana or Jardiance, an SGLT2 inhibitor. Or we compared them to people just on an ACE and ARB, our standard therapy, what we've been using for years, decades. And then we looked at, in the middle, primary composite outcome. Doubling of the creatinine, which is a loss of GFR by 50%, kidney failure, or tombstone death, okay? And then they looked, and they said, if you're on combination therapy, the likelihood of getting to one of those endpoints, dying or being on dialysis, it would take 17 years if you're on the combination, as opposed to those on an ACE inhibitor or ARB, 9.6 years. In essence, by being on this class of medicine, adding to standard therapy, you're preventing dialysis for about 7 years. $80,000 a year for 7 years. So they're expensive medicines, but there's a lot of lobbying that Medicare, insurance companies should start paying for this stuff, because the improvement in quality of life, lifetime, and cost is substantial. Ending thoughts, this reviews everything. You heard me. If you weren't sleeping, you don't need to read this. You can read it later. And with that, I'm going to thank you for your attention. Thanks.